Well, we have, fortunately now, a really pretty vast expanse of agents to consider treating patients who have symptomatic bone metastases, whether they're androgen sensitive or castration resistant. Let me just sort of restrict my comments to patients who have castration resistant prostate cancer. So back in the early 2000s, we had the approval of zoledronic acid, which is an intravenous infusion medication given every 3 weeks, designed to reduce the complications of, or the onset of skeletal-related events. The drug is administered intravenously over about a 15 to 30 minute time frame. It has a renal clearance mechanism, so we do have to check creatinine beforehand. But this was really, and still is, the only bisphosphonate approved for the prevention of skeletal-related events for men with metastatic castration-resistant bone metastases with prostate cancer. In the last few years, we've also had the approval of a subcutaneous administration monoclonal antibody known as denosumab. So this drug is given subcutaneously, so it's easier to administer than an intravenous. And in a head-to-head trial, and now published in peer-reviewed literature, really nicely showed that it actually not only was non-inferior, but actually superior in terms of delaying the onset and prevention of skeletal-related events. It's a monoclonal antibody. It's cleared through the reticuloendothelial system, so you don't have to routinely check a creatinine level. Both the denosumab and zoledronic acid, because they work by as anti-resorptives, or work on the homeostatic mechanism of bone formation and bone resorption, and sort of preventing this vicious cycle that bone metastases create, one has to very carefully monitor for calcium and vitamin D, which is important in the maintenance of and regimen for both. Both can cause a rather unique adverse event known as osteonecrosis of the jaw, which is not fully elucidated but has to do with really very poor bone healing at the gum line between the teeth and the gum line, and can be a very devastating complication. Now, fortunately, it's pretty uncommon. It has an incidence of about 1% per year, which can be progressive with each subsequent year of use. But that said, if you do very good dental inspection, dental hygiene, then that is a way to mitigate against that complication. The development of zoledronic acid and denosumab is really very important in delaying the onset of these skeletal-related event complications. Now, neither of those two drugs has ever been shown in a phase 3 trial to improve survival or delay mortality, but they are both beneficial and are essentially part of all international guidelines for consideration for prevention of complications of bone metastases in the CRPC patient.